Okay, we're going to talk about Hodgkin's lymphoma. It's a malignancy of the lymphoid tissue that initiates in a single lymph node. They experience generalized painless lymphadenopathy, which means they have enlarged lymph nodes that a lot of times are just painless. They're just rubbery under the skin. They don't really know what the cause is. Prognosis is really good. There's a 5-year survival rate of 90%. Late occurrences after 5 to 10 years, not uncommon. So it does generally come back. There's 2 types. There's A, which can be symptomatic, and B, which they might have the presence of symptoms with fever, night sweats, or weight loss of 10% or more. Type A is the one with generally a better prognosis. So remember that there's 2 types. It talks about lymphomas on 828 in your book. So make sure you look at the information. So diagnosis is actually made by excision of the lymph node for biopsy. So we're actually going to do a biopsy. Lymphatic organs that might be involved are thymus, bone marrow, lymph nodes, and spleen. Staging's done by surgical laparotomy, so they actually go in, they take a piece of that, and they talk about a Reed-Sternberg cell. It talks about that in your book. It usually starts in a single lymph node or a single chain, and then they contain a certain cancer cell. Hodgkin's lymphoma spreads predictably, unlike non-Hodgkin's. Non-Hodgkin's don't have the Reed-Sternberg, and they have a lot of different types. So staging is just a single lymph node region or a single extra lymphatic organ. Stage 2 or more lymph nodes, or both on both sides of the diaphragm, or localized involvement of extra lymphatic organ. And stage 3 is lymph nodes on both sides of the diaphragm, localized involvement of one extra lymphatic organ, the spleen, or both. Stage 4 is diffuse involvement of one or more of the extra lymphatic organs with or without lymph node involvement. So there's a picture there of that Reed-Sternberg cell. So assessment, like I said, you're going to see an enlarged lymph node. A lot of times they're cervical or supraclavicular. As you can see, that's fairly close to the airway. So if you had a fairly large lymph node in that area, probably one of the concerns I would have is airway. Anemia, they may experience thrombocytopenia, elevated leukocytes, and decreased platelets. Fever, increased susceptibility to infection, anorexia, weight loss, malaise, possibly bone pain, night sweats. Sometimes they experience pruritus, which is itching or pain in that affected lymph node, especially after alcoholic consumption. So what do we do for these particular things? We can do radiography, radiotherapy, or radiation. We can do chemotherapy, and we can do a splenectomy. Complications of Hodgkin's is actually liver failure and non-lymphocytic leukemia and non-Hodgkin's lymphoma. So initial diagnosis, you see there, you can see the spots that are noted. And then we give them adriamycin, blinozane, Velben, and dacarbazine. Those are all chemotherapies. You can see the big improvement after just 2 cycles of chemotherapy with those particular drugs. If the patient has this, we're going to protect them from infection because they're going to be immunocompromised. So one of our key things will be to protect them from infection. Monitor their temperature. Again, you want to know what your oncologist considers a temperature. Generally, it's 100.5 or greater. Watch for anemia. We know that if they're having problems, they may have a decrease in red blood cells. Provide adequate rest, again, because they'll be fatigued. Encourage high nutrient foods. Provide emotional support for the family, and preoperative and postoperative care for a laparotomy or a splenectomy. A laparotomy is actually an abdominal surgery. We may go in and take the spleen. You've heard me talk about hepatosplenomegaly. That's where the liver or the spleen is enlarged. If you would ever, a patient would complain of abdominal pain, generally we do not palpate those things, but you definitely don't want to palpate an enlarged spleen because that could cause the spleen to burst. So that's something that you want to keep in mind. Treatment options, like I said, chemotherapy is what we generally use for Hodgkin's lymphoma, with a pretty good result. And the splenectomy, we also, before we do a splenectomy, we make sure all of their vaccines are current before we do the splenectomy, because remember, the splenectomy has several parts of pulp. It has white pulp and red pulp, and those all have to do with synthesis and growth of those cell components, white blood cell components, red blood cell components. So if we want the patient to be less likely to have problems with infections, that we have vaccines, so we'll go ahead and give them the vaccines for those things that we do have vaccines for. These are the interventions I just talked about. Of course, if he has a laparotomy, which is a abdominal surgery, we're going to take care of him as a basic abdominal surgery. He'll come back. If it's not laparotomy, where he has the three little suture lines with steri strips on them, and he actually has an abdominal surgery, he'll come back with an NG tube and an abdominal incision and all those things. And we'll do basic care, turning, coughing, deep breathing, monitoring for DVTs, making sure he gets up early in his stay, and those kinds of things. So we've been talking about some cancers. We've talked about leukemia. We've talked about Hodgkin's. We're now going to talk about care of the cancer patient. And it's in chapter 20 in your book. I actually have my old book and cannot find the edition of my new book with this chapter in it, so my page numbers might be a little off. Cancer is a neoplastic disorder that involves body organs with manifestations that vary just according to the body system and the type of tumor cells. Cells lose their normal growth controlling mechanism, and they start to grow uncontrollably. So you've heard me talk about before, a lot of the things that we talk about that cause cancers actually cause damage to the normal cells. And each time the normal cell is damaged and has to be replaced, that's when it's potentially going to turn into an abnormal cell. This cancer can produce very serious health problems, such as impaired immunity, which makes them more apt to get infection. Hematopoietic blood-producing function can be changed, altered gastrointestinal structure and function, motor and sensory deficits, and decreased respiratory function. So there can be a lot of serious health problems with cancer. Some of the terms that we want to look at, neoplasms are a new formation. So if you read that, carcinomas is a malignant tumor arising from epithelial tissue, and sarcomas are a malignant tumor arising from non-epithelial. So it doesn't arise from the outer skin layer, also not a layer of the alimentary canal. So some other definitions: if you have an adenocarcinoma, then it's a glandular tissue. An angiocarcinoma, it's part of the blood vessels. Basal cell is an epithelium. Usually it's on sun-exposed areas, like on your nose, you might have a basal cell, or on your ear. Embryonal is in the gonads. Fibro is part of the fibrous tissue. Lympho is the lymph tissue. Melano is part of the pigmented cells of the epithelium. Myo is muscle tissue. Osteo is bone tissue, and squamous cell is part of the epithelium. That helps us define what part of the tissue or what parts of tissue are actually involved. So grading and staging, that's the method used to actually describe the tumor. And usually it's based on what the cell looks like. So we go in and we do a biopsy, and we look at the extent of the tumor, the extent to which it's malignant, has increased in size, the involvement of any regional nodes, and metastatic development. So usually a stage 1 has some alterations to the tissue, but it's not expanded outside. And as you get through the staging, you'll find that it's more and more expanded. Grading a tumor classifies the cellular aspects, like I said, and staging classifies the clinical aspects and the degree of metastasis. So differentiation is the degree to which it looks different than its parent tissue. That's why sometimes you'll hear us refer to, let's say we found a tumor in the lung, and we'll say it's metastatic breast tissue, because when we take it all the way down to what kind of parent tissue it was, it looks like breast tissue and it has moved to a different site. So it has metastasized somewhere else. Metastasis is spread of cancer from the original site to other body parts. Like I said, it's going to look somewhat like the tissue that it started or originated at. You can have local seeding, which is distribution of shed cancer cells that occur in the local area. You can have bloodborne, where the cells enter the blood and they move through the blood to other areas. Or you can have lymphatic spread, and that's where it spreads through the lymphatics, and those are more susceptible to early metastasis. So cancer sites and the common sites of spread. Bladder cancer usually goes to the lung, the liver, the bone, the pelvis, some retroperitoneal structures. The brain is the central nervous system. Breast is goes to the bone, the lung, the brain, the liver. Colorectal usually to the liver, the lung to the brain and the liver. Prostate to the bone, the spine, the lung, the liver, the kidneys. And testicular, the lung, the bone, the liver, the adrenal glands, the retroperitoneal lymph nodes. So depending on the extent of the metastasis, depends on how much treatment we may be able to give to the particular patient. So cancer development, you've heard me talk about it before. It has to do with causing the cells to have to regenerate, and when the regeneration occurs, they have a ability to become abnormal. So some environmental factors that we've talked about, industrial chemicals, like benzene, we talked about with leukemia, drugs, tobacco. Physical things could be ionizing radiation, whether that's from diagnostics or therapeutic x-rays. Like they believe now that a high incidence of thyroid cancer might be from mammographies, because we get mammographies when we first turn, 40, 45 in that age. Can come from ultraviolet radiation like sun and tanning beds, chronic irritation, and tissue trauma. Some viruses are believed to cause some cancers, known as oncoviruses. That onco stands for cancer. Epstein-Barr can cause. Hepatitis B is believed to cause some. Human papillomavirus. Helicobacter has an increase in incidence in gastric cancer. Obesity and dietary factors, including use of preservatives, contaminants, additives, and nitrates. Nitrates are found in bologna and hot dogs. Genetic predisposition. So we know that some cancers have some genetics that we can actually identify, like prostate cancer, breast cancer. So we know that there's some familial clustering, maybe some chromosomal changes. Advancing age is also a significant risk factor. And immune function. Our immune system is supposed to identify abnormal cells. So if we are giving somebody an immunosuppressant, they're more likely to have abnormal cells grow. So patients who get kidney transplants, heart transplants, they're on a lifetime of immunosuppressant therapy so that they can live, will possibly have cancers later in life. So how do we prevent it? Well, one of the things we do is we try to teach people to avoid things that are carcinogens. So we teach people to avoid cigarettes. We tell people to avoid alcohol. We teach people what certain carcinogens are. So we don't want them to eat a lot of nitrates. We don't want them to be, when you're in the room and an x-ray machine comes in, you don't want to be in the room with the x-ray machine. So we teach people the things that they should avoid. Also modification or avoidance of factors associated with the development of cancer. So again, we tell them to avoid the sun. We tell them to put SPF 30 or more on. So we tell them and try to teach them things that will keep them from actually getting cancer. We tell them about screenings. We tell them they need to get their first mammogram by such and such date, and then you should get one every year until you're so-and-so old. You should have your first pap smear by 21, and then every year, and so on. So there's a lot of things that we teach and tell patients so that we can help prevent these sort of things. 7 warning signs: change in usual bowel or bladder function, a sore that does not heal, unusual bleeding or discharge, hematuria, which is bloody urine, tarry stools, which is bloody stool, ecchymosis, which are bruising, bleeding moles, thickening or lumps in the breast or elsewhere. So scrotum, you should check the testicles for thickenings or lumps. Obvious changes in warts or moles, a nagging cough or hoarseness. You've heard me talk about before. 2 weeks of hoarseness with an unexplained reason means that they should be checked for esophageal cancer. Early detection, we do mammographies, we do pap tests, we do rectal exams and stools for occult blood. We also tell patients that by the age of 50, they should have their first colonoscopy. We do sigmoidoscopies. That's looking at the lower section of the bowel. We encourage patients to do self-breast exams and get clinical breast exams. We encourage testicular self-exams, and we encourage skin inspection. All of those things are hopefully we're going to catch the cancers in early stages so that we can do something about them. Diagnostic tests are performed dependent on the suspected primary or metastatic site. And then invasive procedures require informed consent. So if we have to do a bone marrow aspiration, like we were talking about in the last presentation, we would have to do an informed consent. If we're going to do a biopsy, an informed consent. So all of those things where we're actually putting in a needle, getting skin tissue, all of those things need informed consent. And they need to know risk versus benefits before they sign an informed consent. So some of the diagnostic tests that can be done, we do a biopsy, we can do bone marrow examination, we may do a chest x-ray, complete blood count so that we can look at the white blood cell count, the red blood cell count, and the platelet counts. We might do a CAT scan, cytological test. You've heard me talk about those before. That's like when we talked about lung cancer. I talked about getting a sputum for cytology, where you put whatever he coughs up, you put in some formalin, and they take it and they look at slides of it. They might do cytology studies of like a thoracentesis fluid or an abdominal, a paracentesis fluid. They might do cytology. What they're looking for are cells. So they do different cytologies when they're looking at the cells to see how abnormal they are. Liver functions, we're going to look at those tests, especially if we're considering chemotherapy. We want to look at those. You want to look at the AST, the ALT, but also look at the alkaline phosphate. A lot of times if they have like bone cancer related to like a prostate, a lot of times you'll see an alkaline phos that increases. We'll do an MRI, an evaluation of those serum tumor markers. So if we know there's a possibility you have prostate cancer, we're going to check PSA. If there's a familial tie, we may check the tumor marker for breast cancer. We'll do a proctoscopy examination, a radiographic studies, radioisotope scanning, like that picture of those Hodgkin, that's radioisotope scanning, and then look at tumor markers also. So we're going to talk more about some of these. Biopsy, definitive means of diagnosing cancer. It provides histological proof of malignancies. What we do is aspirate the cells and then we look at it. If we do an incisional one, we'll actually take a wedge of the suspected mass. Excisional is a complete removal of the entire lesion, so we might do that, go in and actually take out the entire lesion. Staging, we'll do multiple needle or incisional biopsies in the tissue where the metastasis is suspected. Interventions, it's usually done in an outpatient surgical setting. Again, we're going to do an informed consent, and then we're going to teach them things that they need to be aware of. This is a particular as a liver biopsy, or actually a lung biopsy. These patients probably should be monitored for a while. A liver biopsy, a kidney biopsy, any of those, the first thing you should do is make sure that you have some kind of PT, PTT, INR, fibrinogen levels, any kinds of levels on clotting before they do those. Tissue examination, we do frozen sections or we can do paraffin sections. The frozen section can be prepared in minutes so that diagnosis can be done quickly. Paraffin sections take a longer time. They take 24 hours. They give clear details. But they may do frozen sections because they can get that diagnosis. If they're in the surgery suite and they're trying to decide whether they're going to remove more tissue based on what type of tumor it is, they may do more of a frozen section so they can get that back quickly. Some other terms, adjuvant is therapy supplemental to the primary therapy. Adjuvant therapy, when I think of, or treatment, when I think of that, is like acupuncture, maybe some essential oil therapy. It's something that supplements what we're actually doing. Palliative procedures, those actually are not going to cure the cause, but they relieve some of the symptoms. So I've seen them do like radiation for esophageal cancer. It wasn't going to get rid of it, but it would shrink it so they could at least swallow. I've seen them do it for bone cancer, radiation for bone cancer. It just basically decreases the types of pain they're going to have. They may have surgery. They can do prophylactic surgery. So you've heard, let's see, Angelina Jolie has a family history of breast cancer. So she had a bilateral mastectomy done. That's a prophylactic surgery. So that If there's an existing or a family condition that may predispose them, they may attempt to remove the tissue or organ to prevent the development of cancer. Surgery is a lot of times used to indicate diagnosis, stage, and treat cancer. Curative, we're going to take all gross and microscopic tumors as removed or destroyed. Control surgery is what we call cytoreductive or debulking. Simply means we took out a large portion, but we didn't take it all. We do that sometimes in advanced ovarian cancer. I've heard them do it sometimes for colon cancer. Surgery decreases the number of cancer cells, therefore it may increase the chance that other therapies will be successful. So we can decrease the size of the tumor and see if radiation and chemo can get the rest of the tumor. Palliative, again, is to improve the quality of life during survival time. It's performed to reduce pain, relieve airway obstructions, relieve obstructions of the GI or the urinary tract, relieve pressure on the brain or the spinal cord, maybe to prevent hemorrhage, remove infected or ulcerated tumors or drain abscesses. So there's a lot of different things we can do as palliative. And then reconstruction, rehabilitative, when I think about that, I think of breast reconstruction after a mastectomy. It improves quality of life while restoring maximal function and appearance. So when we think of oncological surgery, some of the adverse effects are going to be loss of function of that specific body part, reduced function as a result of some organ loss, scarring or disfigurement, and there could be some grieving because of altered body image. I can't imagine a patient who gets a double mastectomy, there wouldn't be a little bit of grieving. I know there's some grieving sometimes when uterine or ovarian cancer, if the patient hasn't been able to have children beforehand. Chemotherapy kills or inhibits the reproduction of the neoplastic cells as well as some normal cells. So just because we are targeting the neoplastic cells doesn't mean we don't also kill normal cells. There are some systemic effects that we're going to talk about. Normal cells profoundly affected our skin, hair, the lining of the GI tract, spermatocytes, and hematopoietic cells. So we're going to talk about hair loss. We're going to talk about nausea. We're going to talk about, we talked about neutropenia being a problem. Thrombocytopenia could be a problem. So usually chemotherapy and biotherapy agents are used together. Biotherapy, remember, are things like neutropenia, there's erythropoietin, and then there's a white blood cell that's called I can't think of the name off the top of my head, and then there's one that's for platelets too. So we can use those biotherapies to help build up the hematopoietic cells. Combined with other therapies, chemotherapy can also be combined with surgery and radiation therapy. Sometimes as they look at the tumors, like I know somebody that had a cancer in the rectal area that outgrew the rectal tissue. And so before they took that out surgically, they did some radiation and some chemotherapy to shrink it down so that when they took it out, they hoped that they wouldn't have to do a colostomy, which they didn't have to do a colostomy, but they did possibly seed the abdomen. When they took it out, it was shortly after that they found that he had cancer throughout the abdomen. Seeding comes from when you remove a tumor. A patient has a tumor removed in surgery. Sometimes there's small little cells that are on gloves or instruments that might be seeded into other areas and may cause tumor growth. Surgeons are very, very careful about seeding that stuff, but sometimes they're microscopic cells that break loose and cause that particular problem. Chemotherapy, some common side effects: fatigue, alopecia, which is hair loss, nausea and vomiting, mucositis, skin changes, myelosuppression, so neutropenia, anemia, thrombocytopenia, and we're going to have more discussion about those. So some things about anti-neoplastic chemotherapy itself. We have to follow OSHA guidelines. Usually only specially credentialed nurses can give parenteral chemotherapy. You should be familiar with complications related to administration, safety, side effects, and any nursing parameters. If you're working with a LPN and that you're giving the chemotherapy, you need to make sure that all healthcare providers are familiar with safety and side effects. OSHA guidelines, we have to wear special gloves, we have to have a gown, we have to have a goggle, and it all goes into a it goes into a yellow and white container when we're done, when we handle chemotherapy. So make sure that you are aware of those processes of chemotherapies being used. Obtain complete and detailed instructions about administration. Routine knowledge of procedures for IV administration is not sufficient. I was actually chemo certified when I worked on the oncology unit, and I had to go through special training about how to handle and certain things to look at. Like I said, they're toxic to both cancer and normal cells, so we need to be aware of that. So it could also, if we got chemotherapy on us, it could actually change our normal cells. Persons who are pregnant or considering pregnant should notify their supervisor. Many agents discourage or prohibit pregnant personnel from caring for patients with these particular drugs. Check with another nurse the healthcare provider's prescription and the client record to ensure correct medication. Verify the IV line and placement. You can see a picture there. That's from infiltration of chemotherapy. Chemotherapy will eat the skin. It'll cause an extravasation. Make sure if you're giving a particular drug that you know what the antidote is in case we have to put antidote into the tissue to reverse the extravasation. Always make sure if you're putting in a peripheral line, you check that peripheral line and make sure that it is in the vessel like it needs to be. If a vesicant drug is administered through a peripheral line, you need to stay with the patient and check the IV line placement and patency often. If you do use a peripheral site, they get a new site each day they get chemotherapy. You dispose of all IV equipment in the special waste receptacle, which is a white and yellow plastic container. There's a table in your HESI book on 437. It's table 4-37 that talks about giving chemotherapy. So make sure and look at that. GI concerns, you'll assess them. Cachexia is very thin with almost like it looks like skin pulled over their bones. Anorexia is the loss of appetite. There's changes in taste. They have early satiety, so they don't feel hungry. They might eat a few bites and then they'll say they're full. They honestly have signals from their body that says they're full. So interventions, we want to get as good at, when you look at their calories and their protein, you want to get it in as few of bites as possible because they're possibly going to be not hungry. And it's a real emotional struggle with family. Because family feel like the number one thing they can do is keep a patient warm and feed them. And when patients don't want to eat and the family knows they need to eat, it becomes a real struggle between the patient and the family. So you really need to work through that when you're talking to patients and family. If they have nausea, we do have drugs that help with nausea. So nausea related to treatment, we're going to give antiemetics. If we know that this chemo causes nausea, we should give what we call anticipatory antiemetics. So we're going to give them before chemo. We may give them during the acute phase, so within the first 24 hours of chemo, and then we may give it after the first 24 hours and breakthrough. So we really need to time the antiemetics so that we can really get the most valuable calories and protein into the patient that we can. So coordinate with the patient and the healthcare provider to ensure adequate control. Make sure they're given before chemo and based on the response and duration. So like I said, during chemo, after chemo, during breakthrough, continue the antiemetics even if it appears controlled if they're still getting chemotherapy. Because chemotherapy is what's causing it, and even if we get it under control, they're still going to have chemotherapy, so it still could get out of control at any time. So we want to control that. When he stops taking them, the patient should start them again at the first sign of nausea. Next thing is alopecia. That's very common with certain chemotherapies. Again, if you're a chemotherapy certified nurse, you're going to know which ones those are. It's usually temporary. It will regrow. It occurs about a month after the chemotherapy. And you're going to have to teach them about scalp injuries because they're not used to not having hair. So, who would thought I had to put sunblock on my head? Who would think I need to wear a hat when I'm outside? I don't think of that normally, but if I don't have any hair, somebody's going to have to tell me that. So teach them. Hair growth commonly comes back a different color, sometimes a different texture, sometimes a different thickness. So make sure, and then help the patient cope with body image changes. This cap is actually filled with ice or a coolant that we know certain chemotherapies cause a problem with the scalp, so we could put that cap on during infusion of those chemotherapies. So like I said, preventing injury is the biggest thing. Sunscreen, head covering. We know when we take care of babies, we always talk about how the head loses the most heat. But when we're adults, we don't think like that. So prevent hypothermia by keeping the head covered, help assist in selection of head covering, coordinate with a hairdresser or a barber. A lot of times they say cut the hair short in the beginning of the therapy so it doesn't fall out in huge chunks. Purchase a wig that's styled like usual. Use caps, scarves, and turbans. Also remember that if they wear a helmet, like a motorcycle helmet, or they wear earphones or headsets or wigs, they need to do maybe a head covering between those things and their head because it may cause skin breakdown. There are some cognitive changes. They call it sometimes chemo brain. It's usually reduced ability to concentrate. They have memory loss and difficulty learning new information during treatment. Most chemo drugs do not cross the blood-brain barrier, but they do have some cognitive changes. It's seen more in patients with breast cancer for some reason. Reassurance can be difficult. Difficulty, it may or may not be a long-term problem. So support the patient, listen to their concerns, try to reassure them, discourage them from other mind-altering behaviors. So that means they don't want to take marijuana, they don't want to drink alcohol, they don't want to do things that'll cause head injury because they're already having some issues and those things will just aggravate it on top of that. Peripheral neuropathy can be a long-term side effect. It causes loss of sensation in the hands and feet. Other side effects from peripheral neuropathy can be orthostatic hypotension, erectile dysfunction, neuropathic pain, loss of sensation, and constipation. That has to do with, several of those have to do with autonomic neuropathy that we talked about in diabetes. It can come from chemotherapy and radiation therapy. Interventions is to protect them from injury, so good foot care, monitor the temperature of their bath, their food, the outside. They don't want to be outside in extremes. They should wear gloves when they're cooking, when they're gardening, or washing dishes. We want to monitor for prevention of falls. We want them to intake high fiber foods and high amounts of fluids if possible. And if they have hand or foot movement problems, we may suggest some occupational therapy. Radiation therapy destroys the cancer cells with minimal exposure to the normal cells. It's designed to hit the tumor itself, so it may hit some surrounding tissue as we go in. If you're looking at a radiation treatment to a lung cancer, there's several layers of skin before it actually gets through the lungs that may actually cause some issues. But it's designed to damage cells so that it damages cells and they die and they're unable to divide. It's effective on tissues directly within the path of the radiation beam, which is good in some ways, but in others, like if we do a radiation beam through the abdomen to a colon cancer, it's actually going to possibly cause some other issues in that area. So we want to look at those. So there's external beam. External beams, the radiation source is external to the patient. We're going to instruct them on skin care. Patient does not radiate radiation, and they do not pose a threat to anybody. They're always worried about, oh, am I going to be radioactive? Generally, you are not. They do have markings on their skin that they should not try to rub off, and they should not put any oily creams or lotions or any kind of skin care in that area without checking with the oncologist. Brachytherapy is a radiation source is direct, continuous contact with the tumor tissues for a specific time. So sometimes the source is within the patient for a given time. The patient will emit radiation and pose threats to others. It can be an unsealed source or a sealed source. Unsealed is administered via oral or IV route, and it's instilled into body cavities. It's not confined to one body area. It may enter urine or stool, which could be radioactive and pose threats to others. Most sources are eliminated from the system within 48 hours, and then neither the client or their excretions are radioactive or harmful. So I tell patients that have these particular kinds of treatments that after 48 hours, they'll be okay, but they shouldn't, like a pregnant patient wouldn't want to necessarily use the same bathroom as a patient who has this type of therapy. Or toddlers, you wouldn't want them to be playing in this stool or the commode or anything like that. Not that they would, but that's a possibility. Sealed radiation sources, those are sealed. They're temporary or permanent radiation sources, so it's like a solid implant. It's implanted within tumor target tissues. It mediates radiation from the implant, but the excretia, so their stool and their urine wouldn't be radioactive. Sealed ones, I'm thinking like a cervical cancer. You might have a sealed placed into the vaginal area against the cervix for an amount of time. Sometimes we put in brachytherapy beads into the prostate. Those usually removal of sealed traditional sources when they're no longer radiation. Inform the patient the cancer is not contagious. Inform the female that she can resume intercourse after 7 to 10 days if the implant was cervical or vaginal. You can provide a douche as prescribed if it was a cervical implant. May prescribe a saline ready-to-use enema. Patients need to notify the physician if they experience nausea, vomiting, diarrhea, frequent urination, vaginal or rectal bleeding, hematuria, foul-smelling vaginal discharge, abdominal pain or distension, or fever. Some of the side effects: local hair loss, altered taste or sensations. Local skin changes and hair loss are often permanent. Altered taste is believed to come from metabolites from damaged cells. They may develop an aversion to meat. If the head and neck are radiated, they may have trouble swallowing. We'll need to work with a dietitian. That may have, it may cause what we call xerostomia. That's XEROSTOMIA, which is severe dry mouth. They may have mucositis and stomatitis, which is dry mouth. And we would do those saline rinses, maybe some salt rinses. We would look at artificial saliva possibly. Xerostomia can lead to tooth decay. They need to see their dentist regularly. Fatigue is a big thing with radiation therapy because of the increased energy needs to destroy damaged cells, to repair those damaged cells. Some degree of bone marrow suppression may also occur. Radiation tissue damage of normal cell leads to tissue fibrosis and scarring. If in the abdomen, it can lead to constipation and possible GI blockages. Not all patients react to the same dose of radiation. It's based on their genetic makeup and how sensitive their cells are to that. And then bone tissue may become brittle and less dense, so they could actually end up with pathological fractures. So we'd want to be extra careful with them moving or transferring or fall risk. Skin care, like I said, may be dry, might break down. We don't want them to remove the temporary tattoos. We want them to wear soft clothing over the area. Only use skin products that are actually recommended by the radiation therapy team. That area that's being irradiated needs to stay out of the sun. Bone marrow transplantation is where we actually replace stem cells that have been destroyed by high doses of chemotherapy or radiation therapy. So generally, if we're doing a bone marrow transplantation, you're going to get some high-dose chemo or some high-dose radiation to kill all of the stem cells that you have. And then we're going to go back in and replace those with a bone marrow donor. You'll commonly use this with leukemia and lymphoma. It can treat other cancers such as neuroblastomas and multiple myelomas. The goal of the treatment is to rid the body of the leukemic or malignant cells through the high doses of chemotherapy and whole body radiation and replace it with donor cells. Donor cells can be allogenic. The stem cell donor is usually a sibling parent with a similar tissue type or a person that's not related, so an unrelated donor, but they have similar tissue types. It can be syngenic, which is stem cells are from an identical twin, or it can be autologous. That's the most common type, where they receive his or her own stem cells. They're harvested during disease remission and stored frozen to be infused later. So the procedure, we go through harvest. That's where we take peripheral blood stem cells, the blood from the bloodstream during a 4 to 6 hour process called apheresis or leukapheresis. We can get them from the bone marrow, where we harvest them from aspirations from the iliac crust to retrieve sufficient bone marrow. The marrow of the client is filtered to make sure all cancer cells are removed. Allogenic are transfused immediately. Autologous marrow is frozen for later use. Conditioning is immunosuppression therapy regimen used to eradicate all malignant cells and provide a state of immunosuppression and create space for the engraftment of new marrow. Then the transplantation, the stem cells are administered through a central line in a manner similar to a blood transfusion. They're administered by IV infusion or IV push. And then engraftment is where the transfused stem cells move to the marrow forming sites of the recipient's bone It occurs when the white blood cell, erythrocyte, and platelet counts begin to rise, and then we know it's successful. It may take 2 to 5 weeks, and then post-transplant period, they're at high risk for infection, bleeding, or neutropenia, and thrombocytopenia. Those are our major concerns until engraftment occurs. Complications of bone marrow. Failure to engraft. If the stem cells fail to engraft, the patient will die unless another transplantation is attempted and successful. There's something they call graft versus host disease. The patient's body cannot identify that the stem cells are foreign due to immunosuppression, but this condition occurs when the donated graft cells see the new host cells as foreign and create an immune response toward the new host. Treatment is immunosuppressive drugs, but has to be done extremely carefully since the patient's already immunocompromised. Infection is a concern, also could keep new stem cells from engrafting. And then veno-occlusive disease is occlusion of the hepatic venules by thrombosis or phlebitis. Usually they complain of upper right quadrant pain. They develop jaundice or ascites and weight gain and hepatomegaly. Early detection is critical since there's no way to open up the hepatic vessels. We treat the patients with fluids and supportive therapy. So we want to look at some oncological emergencies. We talked a lot about infection being one of our biggest concerns when we talked either about leukemia, Hodgkin's, the different cancers we've just been talking about. So key is prevention of sepsis, so strict adherence to aseptic techniques during invasive procedures and during contact with non-intact skin and mucous membranes. Teach the patients and the families early manifestations of infections and when to seek assistance. Management includes decreasing infections with antibiotics, or anticoagulants if they develop early DIC, which is disseminated intravascular coagulation. If you remember, what happens is clotting starts to occur in the peripheral vessels, and we use up all our clotting factors, and so then we start to hemorrhage from all of our other areas because all of our clotting factors have been used. It's a very serious condition. If hemorrhage occurs, rapid treatment with clotting factors is needed. So some of those clotting factors we talked about, factor 8, factor 9, factor 10, cryoprecipitate, plasma. Also, they could develop SIADH. Remember when we talked about lung cancer? That's the syndrome of inappropriate antidiuretic hormone. It occurs commonly with the small cell lung cancer, but other cancers can cause it. ADH is secreted in the kidneys, hold water in the systemic circulation, and then they get retained water and dilution of the sodium, so their sodium levels drop to 115 to 120, which we know is when they could have seizures. Signs and symptoms include weight gain, nervous system changes, personality changes, confusion, muscle weakness. Interventions: fluid restriction, no tap water, patient safety, increased sodium intake, and demeclocycline is one of the drugs that we talked about that could be given for ADH. Another oncological emergency is spinal cord compression. The tumor either invades the spinal canal or the spinal bone, collapses due to tumor degradation. It may begin in the spinal cord, but it more often spreads from the lung, prostate, breast, and colon. So it might start as a tumor in the spinal cord, but more likely it's metastasis. The level of the spinal cord compression can lead to paralysis, which can be permanent, or it can lead to loss of neurological function, which has a very negative impact on the quality of life. Assess for neurological changes like back pain, muscle weakness. a sensation of heaviness in their arms and legs, numbness and tingling in their hands and feet, inability to distinguish hot and cold, and unsteady gait. Sometimes they'll have problems with constipation, difficulty starting and stopping urination, or incontinence. Treatments more palliative. We use high-dose corticosteroids to decrease the inflammation. We might use radiation. We might do surgery. We might use a back or neck brace, possibly chemotherapy and radiation to shrink the tumor. Just depends. And then oncological emergencies. Hypercalcemia is a concern. Up to a third of patients with cancer may have. Symptoms are nonspecific. They could develop skeletal pain, kidney stones, abdominal discomfort, altered cognition. We see serum levels rise gradually without symptoms. When found, the calcium is extremely elevated. Ionized calcium is another calcium level we can draw. It's the best indicator. We see it in breast, lung, renal cell carcinoma, sometimes multiple myeloma. I've seen it a lot in multiple myeloma. Adult T-cell leukemia and lymphoma, most commonly also. Tumors secrete their own parathyroid hormone, which causes release of the calcium from the bone. Also, secretion of vitamin D analogs are coming from the tumors that also cause higher calcium levels. Decreased mobility and dehydration worsens the condition, and that makes sense. I told you, if a patient's on prolonged bed rest, they're going to lose calcium from the bone, and that loss of calcium is just going to add to the release of calcium, and you're going to have a higher calcium. They experience fatigue, loss of appetite, nausea, vomiting, constipation, increased urine output. More seriously, they're going to have severe muscle weakness, diminished deep tendon reflexes, maybe a paralytic ileus, dehydration, and changes in their electrocardiogram. We'll give them biphosphonates. That's like Fosamax. We'll give them oral glucocorticoids. Can temporarily decrease the levels, or dialysis. And I've done dialysis on patients with elevated calcium, and basically the order is to keep them on there until we have the calcium level drop, and that may be 5, 6 hours, 7 hours until it drops. Long-term control is treatment for the cancer. They can develop superior vena cava syndrome. That's actually a obstruction or compression of tumor by the tumor, or clots that lead to congestion of the blood. It's usually in the cranial neck or upper extremities become congested with blood because of the block of the return of blood from the head, neck, and upper trunk. They usually get gradual development, so they get this collateral circulation. You can see on the man that is there, he gets collateral circulation, so you see these blood vessels that actually they're kind of like varicose veins, which is very rare to see on the torso. You'll see that one side is swollen compared to the other side usually. It comes sometimes from lymphomas. Lymphomas can cause tumors in the mediastinal area. It can come from a thyoma, so a tumor in the thymus gland, lung cancer, breast cancer. Early manifestations, a patient will wake up at night with edema of the face, around the eyes, with a tightened shirt collar. It develops engorged blood vessels and erythema in the upper body, edema in the hands, the arms. They may develop dyspnea and epistasis. Late manifestations are hemorrhage, mental status changes, decreased cardiac output, airway obstruction, and hypotension. We'll do high-dose radiation to the upper chest to provide temporary relief. Long-term control is use chemotherapy. Surgery is not generally done. A metal stent can be placed into the superior vena cava to keep it open, with a follow-up angioplasty to keep that area open. Tumor lysis syndrome, large amount of cells are destroyed. It's actually a good sign because if you're doing chemotherapy or radiation therapy, the goal is to destroy those cells. So a large number of cells are destroyed, but they release potassium and purines into the blood system. So although it's good, the body may not be able to eliminate all that potassium purines, so they end up with hyperkalemia, hyperuricemia. Uricemia causes gout. Hyperphosphatemia, that can cause particles under the skin or cause the patient to itch tremendously. So it leads to tissue damage, acute kidney injury, and death. Cancers sensitive to this kind of treatment are leukemia, lymphoma, small cell lung cancer, germ cell tumors, inflammatory breast cancer, melanoma, and multiple myeloma. So just keep that in mind. If you're having a patient that's getting chemotherapy, you want to watch them for these particular symptoms, and you want to watch your BMP or CMP for changes in your phosphorus, changes in your, you might see changes in your BUN, and you may see changes in your potassium. They experience lethargy, nausea, vomiting, anorexia, diarrhea. Their urine might be cloudy. They might have flank pain, muscle weakness, and cramps. So keep that in mind. Interventions for tumor lysis, increase fluid intake. That's going to help flush that out. So prior to and 3 days after chemotherapy, we should encourage them to increase their intake to as much as 5 liters a day. Encourage them to be consistent throughout the day with fluid intake, and even possibly draw up a schedule so that they're getting enough fluid in. Encourage them to take their antiemetics so that they can continue to drink as much fluid as possible. If they cannot drink due to nausea, regular antiemetic use is needed to help maintain fluid intake. If unable to drink due to nausea, they need to call the oncologist immediately. Possible use of diuretics to help remove waste by pushing fluids through the system, but we have to monitor very closely for dehydration. We might give them drugs for antipurines, and that would be like allopurinol, rasburicase, and febuzostat. If they have a high potassium, we may give them Kayexalate orally or as an enema. If they have severe hyperkalemia, we may give them a dextrose IV and some insulin IV. They may possibly need a dialysis if the hyperkalemia and hyperuricemia cannot be treated effectively those other ways.